This meeting of the Mississippi State Board of Medical Licensure will come to order. And Dr. Loper will lead us in the invocation, and Dr. Kinard will lead us in the pledge.
Let everyone bow their heads and remember that we're in the presence of our Lord and Savior, Jesus Christ. Dear Heavenly Father, thank you for this opportunity you give us today to meet. Please give our words both honor and glory, showing your mercy toward everyone here. And we ask safe travels as we return home. In Jesus' name we pray. Amen.
Amen.
Thank you, Dr. Loper.
You'll turn your attention to the flag for the pledge, please. I pledge allegiance
To the flag of the United States of America,
and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
At this time, I'd like to recognize Dr. Cleveland for the roll call. Thank you.
Yeah, let me find that. How about the state of our pants here? I think they did this morning. Dr. Lippincott. Dr. Lippincott.
Here.
Dr. Loper.
Present.
Dr. Dotson.
Present.
Dr. Givens.
Present.
Dr. Kinard.
Present.
Dr. Gersh.
Here.
Dr. Owens. Dr. Roth.
Here.
You have a quorum.
Thank you, Dr. Cleveland. I'd like to recognize Dr. Katherine Panel, President of the Mississippi State Medical Association, who's here to present certificates for board commission. Dr. Panel.
So Dr. Kinard and Dr. Gersh. So just for a little background for our audience and public here, these are certificates that come from the governor's office for their appointment to the medical board. The Mississippi State Medical Association so kindly frames these for our board members. And so I thought it was appropriate that Dr. Panel presented those today. Thank you, Dr. Panel.
Appreciate that.
Thank you. At this time, we have time for public comment. Do we have any public comment? I would like to take time to pay our respects to Dr. Van Craig, who passed away last month. He was the executive director when I came aboard back in 2014, and he had many years of distinguished service. I had the honor of representing the board at his memorial funeral service on August 31st, which happened to be his 90th birthday. And his grandkids sang him happy birthday. So it was a beautiful service. Anyway, any other comments? If not, I recognize Dr. Cleveland for his report.
Thank you, Mr. President. So we'll get through the boring stuff first. Our licensing numbers, you can see, remained exactly the same. And so the first number you see on licensed issues is the traditional pathway for applying for a license and receiving a license. The reason the restricted temps is at 386 and so high is because this is the time of year that all of the medical students graduate and start their residency programs. And so we have a rush of new residents coming out. And also we have the residents have to renew on a yearly basis until even once they get an unrestricted license. But so that's why you see a large number there. We had 1 new podiatrist and 21 new PAs licensed. Through the compact, we licensed an additional 189. We gave letters of qualification to 33 Mississippi physicians for the compact, and we did 339 certifications to other states. In investigations, we received 101 complaints. We were able to close 11 cases. We opened 24 new ones to give us a running total of 52 open cases currently. The complaints closed within 7 days was down to 27%. As y'all know, after our peer review, we developed a review committee, which has slowed down that whole process. And it especially slows it down during the months where we have committee members take vacation. So anyway, that number's down. You'll see it come back up, I do believe. Additionally, in investigations, we requested 29 prescription monitoring program reports. Of those, we asked for additional information on 13 of them. And we held 3 regulatory compliance meetings with licensees that we just felt like maybe were a little outside of regulations, and we just needed to give them a little push to get them back inside practicing where we thought they should be. So your board in action from the licensing division, Anna Boone presented to Mississippi College of Physician Assistants, and her deputy, Brian Nelson, began the basic supervisory course at the Mississippi Personnel Board. In investigations, Jonathan Dalton and Kristen Wallace, represented the board at the MAFP annual meeting. And investigations, MSBML, myself included, met with other regulatory boards, had a roundtable discussion concerning boutique practices such as IV hydration, stem cell, weight loss, and hormone replacement therapy. This is part of the joint investigations that we've started with the other healthcare agencies, such as Board of Nursing, Board of Pharmacy, and at this last one, we even included cosmetology. So we have 3 new employees. One of them is not here with us today. She had a previously scheduled vacation when she agreed to accept the job. Adrian Brantley is our new deputy director. So she'll fill the shoes of Mike Lucius. And she comes with a wealth of experience. She was at the Department of Environmental Quality prior to taking the job here. We also have Miss Megan Geis right here sitting at the table with Paul Barnes. She is our deputy general counsel now and will be helping Paul with all matters legal. And in the back here, I don't know if everybody can see her, Kara Shirley is our new communications director and responsible for how much improved my presentation looks today over the usual black and white production that I tend to put out, right? The governor has appointed Dr. Carlos Latore to fill in the shoes of Dr. Tom Joyner. We will have an orientation with Dr. Latore on October the 30th and expect him to be here for the November board meetings. Our lease here is ending at end of January 26. And so we are in the process of doing requests for lease proposals as the Bureau of Buildings likes to call them. And so we're working through that process, and we hope to have either chosen to stay here or found a new location sometime in November, and then we'll start the preparations for that process. Just a reminder to y'all, we still only have one consumer member currently. And she is in District 1. So we do it by Supreme Court districts. And I'm still looking for members from 2 and 3. So if y'all know of anybody that may be interested, I'm more than happy to talk to them. Some of them that have talked to me are very busy themselves. And I don't think that Renee Dr. Dotson had somebody that I don't think she's going to be able to do it. So this won't come up till the end of today's meeting, but I'm requesting that we actually have the November board meeting on the 12th and 13th. The IMLC, the Interstate Medical Licensure Compact, will be meeting Monday, Tuesday, Wednesday of that week. I have thrown my name in the hat to become chair, and I will find out at that meeting whether I am successful or not. And then the next day is the administrators in medicine meeting that I would like to be able to stay for, but if the board doesn't want to move to these dates, then I will make arrangements to be back in time for the full board meeting. I would still miss executive committee on Wednesday. Yeah. So with that, you don't have my little Michelin man for asking questions anymore. I've got this fancy thing now. Thank you, Kara. Does anybody have any questions?
And this is Randy. Are y'all still looking for an at-large member from the Coast District?
Yes, sir, we are.
Okay, I can. I'm going to send you a name or two, and we can talk about it, later in the week.
That'd be great. Thank you very much.
I got a question. Do we have authority to check any prescription monitoring programs, or do we have to have special circumstances?
Well, so we can't do it randomly, but we can do it for investigative purposes.
If there's
Yeah.
a reasonable reason.
Yeah.
Okay, I was just curious. Thank you.
Yep.
Thank you for your report, Dr. Cleveland. Any other questions? If not, the next item on the agenda is approval of minutes of the executive committee meeting from July. And does anyone have any corrections to the minutes as distributed last week? If not, we can entertain a motion to approve the executive committee minutes for July 16th.
Second.
All in favor? Aye. Okay, the minutes stand approved. And next item is approval of minutes of the board meeting for July 16th. Do we have any corrections for those minutes as distributed? If not, we can entertain a motion to approve the minutes.
So moved.
Second.
All in favor?
Aye.
Aye. The minutes stand approved. And Dr. Rodney Givens has a report for the executive committee meeting yesterday.
Okay. Executive committee met yesterday. We looked at 6 items that required review. Number one was a Zoom appearance by Dr. Simeon Kwan. That was requesting a exception to the Rule 2080 practice requirement. That request was denied. Zoom appearance by Dr. Jerry Childs. The applicant did not satisfy requirements for Part 2605, Chapter 1, Rule 1.1. Therefore, that request was denied. Zoom appearance by Dr. Deborah Gross. There was a slight amendment to the request for the 2080 rule. However, that request was approved. A Zoom appearance by Dr. Harriet Jones. That reason for that request was exception to Rule 1.4, extended mileage. That request was approved. There was a Zoom appearance by Dr. Aloso Patoki, request for waiver of the Part 2605, Chapter 1, Rule 1.1D. That request was denied, and there was also discussion of a licensure application matter with no action. That concludes my report.
Thank you, Dr. Gibbons. I recognize Dr. Kirk Kinard for a report from the Rules.
Dr. Lippincott, excuse me, sir.
Yes.
You need to take a vote from the full board to approve the actions of the executive committee.
Oh, thanks for reminding me.
You're welcome. That's why y'all keep me here, right?
We'll entertain a motion to approve the report from yesterday's executive committee meeting.
So moved.
Second.
All in favor?
Aye.
The report stands approved. And now I recognize Dr. Kinard for a report from the Rules, Regs, and Legislative Committee.
Thank you, Mr. President. We've been a busy committee. That's our challenge, but what I'd like to do, if it pleases the president and the rest of the board, is start with the first item that we've taken up over the last 6 weeks or so, which is the continuing medical education requirements. And without belaboring the reason why we took this up, I do like to provide context because I think it's important, but just briefly, the history of this requirement and the tediousness with which we regulate this requirement is an issue for both the board administrators that do the random audits for CME and I believe the licensees. And times change and we have to look at rules and regs and be progressive and make updates. And at this time, it's our understanding that most licensees report to either their own specialty digital bank through their subspecialty or specialty, or use CME Broker or one of these digital platforms to help them keep up. There's a lot to do in the day in the life of our licensees, and this has really made it easier and streamlined the process for the licensee and on the back end for those conducting an audit, which is in the spirit of the audit. It's to make sure licensees are performing and keeping up with continuing medical education to make them safe to treat patients. So with that context being delivered, everybody has a copy of some additions and edits that we've made to our own CME requirement rules. So those are before you, and I'll just briefly summarize the pertinent changes that we've made. So you're still required to get the DEA on behalf of the USDA and Controlled Substance Act. You have to get those as you would, and those do still apply to your 40 CME requirement every 2 years. The reporting dates haven't changed. Okay, some of this is stricken on page 2, but it's just to kind of clean it up. So the schedule of requirement and the number of CMEs to be acquired has not changed. It's how they're reported that is the new expectation. And I'll just reiterate, that is to a board-approved digital platform. But if your specialty offers its own digital bank for your CMEs, as for instance, mine and anesthesia does, we have the Maintenance of Certification and Anesthesia Program, MOCA, not to be confused with what some people put in their coffee in the morning. MOCA has a website and a portal that I put my CMEs in. And so I can print out a one-pager that shows you that the American Board of Anesthesia has justified and reviewed my Schedule I CMEs as appropriate and accepted them. And so I can provide that very easily. In those instances, you're not required to be duplicative and then go and register them on CME Broker and also have that available. So I don't want to confuse the matter, but these are the things that we're asking licensees to do that are different. The digital reporting so that we can facilitate the audit process on behalf of the licensees and the board mutually. So if you've had a chance to review these, I'll entertain questions about any of the changes and or any of the strikes at this time. But I hope that provides the context for the why we felt the need to update the requirements. Any discussion on those or points of clarification?
Is this going to be required to renew licensure?
Yes, you'll have to attest that you were.
CMEs are reported every other year. So it's been a part of requirements to maintain licensure since essentially the creation of CME. I mean, so the problem we ran into is when we did an audit, only 46% of people were compliant. It was either go down this path or go down the path of not requiring CME anymore.
So if you'll allow me, Mr. President, there are only 3 states that don't require CME reporting. So that is not a national standard that we felt should be entertained. And I don't think you would expect a lot of pushback on licensees that most specialty societies are requiring probably more than 40. So it's not something that we're asking you to do above and beyond. Typically, we haven't gotten reports that there's a lot of consternation about having to do 40 CMEs. It's changing the way that we receive them, which I think will make it easier on the licensees, because one of the problems is when you are audited, you have to present the confirmation of the CMEs that you completed. And sometimes that's just having to go back in files or emails and find this one-page report and print it out. If you just set a new expectation for yourself that those are banked for you, or you bank them upon completion, then it's really easy for you to access to, and it's really much easier for us to access. The audit is not an exercise that is done by the board for punishment. It is simply to monitor and ensure compliance, period. So nothing in these changes does anything but make it easier on both sides to meet the requirement.
So in other words, you can kind of have your CME in a different repository.
Yeah.
And then just simply forward it to the licensure board for verification if asked.
Correct. I mean, so we'll still do a % audit, and we will modify the renewal questions. So when it says, have you completed your 40 CME for this 2-year cycle, it'll be, I have an account with CE Broker, I have an account with ACCME, or I'm board certified. will be your three options. And so then we would be in touch with you to get the information on how we retrieve that information and still make sure that people are being compliant. So the percentage is actually very small. So
So the licensees they don't have to submit this to the board. The board will just audit randomly.
correct.
Okay.
And if they come up in the random audit, then they would have to submit it to us, right?
Yeah.
Either the report like Dr. Kinard was talking about, or a report, if they're not board certified, a report from CE Broker or from ACCME. Those are the two known entities that currently do it.
So the only change is they just have to have them recorded,
Correct.
CME.
In a manner that we can verify that they are doing their CMEs. I mean, and y'all may remember when I reported last on this and started this process, two of our licensees turned in grocery list instead of CME list. Okay. So this will make it much cleaner for us and for the licensee.
Thank you.
So just a hypothetical scenario is a random audit of 5% of licensees. 50% of those are maintaining board certification. So those licensees would be required to show that they are in an active maintenance of certification mode, that they're meeting the requirements of their specialty board. End of story. Those that are not, that can't produce that, would be required to report their CMEs as they traditionally have, just through a digital platform that's accepted by the board. That's it.
Okay.
We make a motion? I make a motion that these, I guess will be modification of the CME requirements be adopted.
I'll second it.
All in favor?
Aye.
Any opposed? Any abstentions? The rules and regs report is approved.
Yeah, one more.
Oh, sorry.
Yeah, the next area of consideration is in part 2630, chapter 1, collaboration with nurse practitioners and supervision of certified registered nurse anesthetists. So you also have that at least on your digital menu here, and I've got a printed copy of this. Again, to provide just a brief amount of context, if you will, if you'll please with the board. A year or so ago, there was a request of the board by someone that attended the open board meeting to provide a declaratory clarification statement about this rule. And at that time, we didn't feel it was necessary, but to provide such a statement, but in review, we thought it was necessary, like we've done with a lot of other sections and rules, provide an update or clarification of our expectations through the rules. So that's what this committee was tasked with doing with this particular section. And we've done so, and we've done so, I believe, pretty comprehensively, and taken time to deliberate on this because it is a serious topic. But there's a lot of questions about what the expectations are. And so there's a national expectation, there's precedent. We based any of these changes or additions or modifications based on our best evidence that we could find to, again, follow in the spirit of protecting the public and making sure our licensees are clear on the expectations of this particular rule. There the national landscape is, I believe there are 13 or 14 states that don't require collaboration, but as we do with any of our own licensees, and we are a state of collaborative practice with APRNs. And that is not our decision. It is in our rules. That's how we conduct our business. CRNAs are APRNs. And so they also require supervision in our state. The changes that you'll see aren't necessarily changes. They're just a clarification of expectations based on the data that we reviewed that leads to the safest practice model. It's no surprise to anyone that this board consists mostly of physicians, and believes that the physician-based care model is the penultimate model for care, for medical care. That doesn't change in the setting of an anesthetic. The collaboration between an anesthesiologist and a CRNA and a primary care practitioner and a family nurse practitioner are different. There are nuances. The delivery of anesthesia is to facilitate a minor or major procedure by a surgeon or an interventionalist. So it's not a treatment in and of itself. It is to facilitate a treatment. That makes it slightly different. So the anesthesia world is slightly different. But the expectations that a physician lead that care are the same. In the committee's opinion, for sure, but we're bringing forth the changes that we suggest to the entire board for full discussion. So if you'll look, thank you for allowing me to provide context for that. Makes me feel better at least. If you'll look, you see anything that's not stricken or added is already in our rules. So just take page 1. We added and collaboration with CRNAs because that wasn't clarified in regards to the extended mileage collaboration point. Waivers to that requirement can be proposed and entertained. None of that changes. We changed nurse practitioner to APRN to just simplify it because, like I said, I'll reiterate, CRNAs, although their practice is nuanced, there are nuanced differences in it. They are APRNs technically, so we just simplified that. And then when we are specifically addressing anesthesia in that care model, we list them as CRNAs. So you'll go to page 2, you'll see 3 definitions that are added. And we didn't just pull these definitions out of our own hat. These are based on American Society of Anesthesiology, which is the largest national professional society for anesthesia. It has been for a long time. Most of the national and international research on anesthesia that has made it as safe as it is, so it can be conducted by non-physicians in a safe manner, was done through this organization. So we define anesthesiologist, we define supervising physician, and we define immediately available. So as it currently stands, an anesthetic in the state of Mississippi actually does not require an anesthesiologist to be present. It requires a supervising physician to be present throughout all phases of the anesthetic. We are not changing that. We are simply saying in the event that the surgeon of record is not the supervising physician, or when the level of the anesthetic reaches a threshold deserving of the specialty availability of a physician anesthesiologist, that they are available in what terms. In the later stages of this, you'll see the terms that set that threshold. So any anesthetic requires a supervising physician, not an anesthesiologist. So we're not changing that. And then immediately available is debated nationally. What does that mean? Does that mean 5 minutes away, an hour away by telephone? What does that mean? Well, the ASA has their definition of what they believe immediately available is. And so for all intents and purposes, we are not changing our expectation from what that definition says, and it's here. So that's on page 2. If you go to page 3, there are no changes. And that refers to the primary care extended mileage rule. Backup emergency coverage, on to page 4, no changes. Page 5 is where the most of the substantive changes occur that we've made. So again, the physician-led model is just the model that the data that we've reviewed, and we haven't been provided new data over the years that's not the safest delivery of anesthesia. So we're basing it on a somewhat national standard. You know, CMS has their standards in order to bill them for services, and they base that on their own data that they review. It's important just to know the landscape of what the expectation is for the safest delivery. So as I mentioned, if you go to the second paragraph under Rule 1.9, whenever a non-anesthesiologist physician will be the only on-site physician, as in some small hospitals, freestanding surgery centers, and offices, the supervising physician shall consider and be versed in certain basic tenets of safe anesthesia practice when serving in this role. That is not a new role. This is happening. So the physician of record, the surgeon, typically is the supervising physician, and an anesthesiologist is not required. Or maybe they are based upon the hospital or center that they're operating in. They have their own individual requirements for that. So that doesn't change. And so the minimum requirement for that is that for that surgeon to be obviously licensed by us and credentialed by whatever center they're operating in, and that they maintain at least ACLS. And so any supervising physician shall meet the following qualifications. This is the kind of the meat of it. And I think it would probably be just easiest just to read it, but I want you to be thinking about this is the clarification of what this board expects the supervising physician to be and to do in any anesthetic. Number 1, the supervising physician must be immediately available during the conduction of the entire intraoperative anesthetic and acute postoperative period. Typically a surgeon is, but the expectation is that they are available. They're the ones performing the procedure, so that's not hard. But then afterwards, until a patient's discharged, they're still under the care, and they need to be of the supervising physician. So number 2, a collaborating physician anesthesiologist shall be available for consult with the supervising physician and CRNA throughout all 3 phases: pre-op, intra-op, post-op. That's what that refers to. Should be available throughout all 3 phases of the anesthetic period for procedures which would: A, reasonably, predictably, or routinely require more than simple assisted ventilation techniques in a spontaneously ventilating patient, or require general anesthesia. So this is important. We don't have evidence that light and even some cases of moderate sedation performed by ophthalmologists, plastic surgeons, other interventionalists, interventional radiologists, that there is a lot of morbidity and mortality associated with what they're doing that rises to a level that we shouldn't provide a threshold for this expectation that an anesthesiologist be involved. Okay, it's a matter of practicality. It's a matter of manpower. There aren't enough anesthesiologists to sit at the head of every bed of every procedure. We know this. We're not trying to imply that anything that would be unable to obtain. But if the case meets something above a spontaneously ventilating patient and the level of sedation is expected to be deeper, it's the opinion of the committee and for the board to consider that we think the expertise of an anesthesiologist should be made available to the CRNA, the supervising physician that's operating surgeon during that whole anesthetic period as well, even if just remotely. Okay, that's what's new. Number 3, the collaborative physician anesthesiologist in this case shall be continuously available by telephone when not on site. That's what's new, but that allows them to be involved in the level of expertise. So what is that? I mean, my barometer for what that level of expertise is, I can only base on the fact that I've maintained board certification as an anesthesiologist. That's all I should base it on. That should not be a surprise. And I know what that training entailed. And so when I'm thinking of how we can deliver anesthesia the safest possible way to patients, I'm going to base it on how I was taught. And I think the morbidity and mortality consequences of delivering anesthetic, a great majority of that can be prevented prior to the patient entering the operating room. So discussions about preoperative care and planning are paramount to not getting into a situation where there's finger pointing about whose responsibility was it and who should have been there, who shouldn't. So this is not a casual requirement that an anesthesiologist be available. This really means that if the surgeon has questions or the non-physician anesthetist, because we're also including anesthesia assistants, which are a newer profession made available, not in Mississippi yet, but it equates to, you know, the nurse practitioner and physician assistant on the chronic disease management side to this. CRNAs and anesthesiologist assistants are performing similar duties, but they have different guidelines that that govern their practice. So there's a close communication gap throughout the whole course of the anesthetic, including into the post anesthesia care unit, where a physician at the highest level of training is made available for consult. And so if you go down to Rule 1.1, that's the last bit of change. It's also important to inform the public in order to protect them of who's in the operating room, who's doing what, who's responsible for what. It's part of informed consent. And that also needs to be a part of the record and explain to the patient that this is your team, your care team for this anesthetic, and here's who's involved. Here's who's on site, here's who's off site, and give the patient a chance to understand who's conducting their care while they're asleep or prior to. So that that is not new, that an informed consent, including the risk of anesthesia, is part of the chart. What's new is that the consent shall 1, 2, 3, 4. It should be signed by the patient or legal guardian. It should be documented in the medical record, not new. Name all responsible physicians of record during all aspects of anesthesia care, including identification of any off-site physician anesthesiologist supervising remotely. So thank you for enduring that and allowing me to present that the best way I knew so we can discuss it. And I'm glad to entertain questions on behalf of the committee, but the committee members are all here, I believe, except Dr. Owens. So
So thank you very much for that very thorough explanation of what you do, but I do have a couple of questions. On page 1, where you're defining what CRNAs are. So the language got a little circuitous for me. So a couple of double negatives in there. So is it establishing that a CRNA can have a collaborating anesthesiologist that is greater than 75 miles away?
yes,
Okay, all right. And then
it doesn't put that mileage requirement on the remoteness of the anesthesiologist.
okay, you just double back on
Yes.
There is no 75-mile rule
Right.
for the anesthesiologist.
Okay.
That doesn't exist for the anesthesiologist
Okay.
because you're going to have a physician present in the operating room
Okay.
Yeah, that
understood.
that would serve
All
them.
right, then that clarifies that language. Moving back into the section on requiring an anesthesia consult when there is a surgeon present as the lead of the anesthetic team.
right.
All right, so now you're saying that if I'm a surgeon in a rural hospital that does not have an anesthesiologist based on how the hospital staffing,
That's right.
and I am board certified in general surgery, and I am ACLS certified and I am ATLS certified, you're telling me that I still have to have an anesthesiologist on phone on remote consult before I can do my case?
Yes.
All right, so was there any thought given to where this bank of anesthesiologists were going to come from?
Yeah, well, that's why we are not requiring them to be in a mileage restricted area because you then open up the pool of availability of.
So
people
then
to
it
be
is incumbent
consult.
on the practicing surgeons to go out and find an anesthesia consult?
Yeah,
for
not
their case?
necessarily. I think the facility that you're working in would have a duty to provide that, like they do.
It doesn't read as that, it reads as the onus is on the licensee.
Well, could you point to where, because I think that needs to be clarified for sure.
Well, it does not, it says that that gives you the supervising physician shall meet these qualifications, therefore, the onus is on the physician to meet this as the licensee themselves. It does not implicate any institution or anything in that.
Yeah.
And it does not say that the responsibility of that could be offloaded to the institution. It states pretty clearly here that it is the duty of the physician to make sure that requirement is met.
Yeah.
So to me, that gets a little cumbersome.
Yeah, I see exactly what you're saying. I think intentional vagueness provides flexibility for practicality for implementing this in a practical way. And if
Is
there's
that
any
the purpose
sense,
week?
well, I think it's almost, for me, I didn't even think of that because I automatically think that it implies that all the things that the institution you're working in and providing that care in would assume a responsibility, since it's going to apply over and over and over, mostly on a daily basis in the operating room, that they would have a duty to make sure there's a network of available anesthesiologists for you, not that your individual,
So you're
surgeon
saying it's
goes
an
out.
institutional requirement, but this reads as an individual requirement.
Yeah, well, I don't know if you want to say it's an institutional requirement and not individual. I think you just make sure it happens. So as a surgeon that's worried about that does not want to go out and do this
Well, if I'm an employed surgeon, then I'm not gonna worry about it because I'm just gonna say to my employee, the board says I have to have an anesthesiologist as a consult. If I am a private practice surgeon, then I've got to hire an anesthesiologist as a consultant for my cases.
That's true.
Yeah,
Like
and
if
I'm
you're
not-
doing your own, in your own surgery.
If I'm not affiliated with any hospital, unless by because the hospital would like my business and they would provide that anesthesia consult for me, that would be very nice. But as an independent
Right.
operator, I've got to have an anesthesiologist in my back pocket.
Yes, that is correct and true. But in a non-opt-out state, I mean, that is the national standard. That they are part of that model that leads that care. That an anesthesiologist do it. And that is to also unburden the surgeon of record. Because there's also a
In one
component
way,
of
but
this.
you burden my pocketbook in another.
Yeah, but I unburdened you from a medical malpractice standpoint in a way because now you have another someone on the case and available for consult that supersedes your level of training to do what that CRNA or whomever is behind the bedside is doing. So at the same time, although it is another consideration you have to entertain and have available, it is protecting you and the patient
Okay,
during that
now,
case.
I'm gonna play advocate. I don't like to give the devil due, but I'm gonna play advocate now. I would, as a general surgeon, I'd push back and say, I'm protecting that patient.
Yeah. Yeah, and
And I'm more of a protection in the room than someone who's greater than 75 miles away on the phone.
yeah, well, in the spirit of preventing a crisis, a lot of that work's done prior to the case in consult, whether it's you or the CRNA, and they have these discussions about level of risk and ASA status. And so you're going into the case at a safer place so that you don't have to react and be the one that saves the day. So there's that component of it. It affords you a chance to consult and the CRNA, unbeknownst to you, to be able to call and get a consult about some concerns they have on a preoperative evaluation for a patient that they might not feel comfortable calling you because you may not agree with them and they don't have a superior in their field to consult with. And so, you know, that could be an issue for them too. They're under a little bit of pressure to just get this case started and get it done. If they were able to consult with someone prior to it, it could change the course of the anesthetic and provide that level of comfort to the anesthetist. So, which does protect you indirectly.
But I'm still gonna advocate here, because then you've added another cost level to the procedure.
Right.
Out-of-pocket expense for that independent practice general surgeon.
Yes.
Because now I have to pay for that anesthesiologist's time that the CRNA needed to call and ask about his pre-op time. I'm forcing us to think.
Right. No. That's exactly what we're supposed to
What
do.
everyone else is saying. So even when I think I have a good idea, I always want to figure out what others will say to me about my idea.
Yeah.
So this is kind of me doing that here, but you've added another cost level into to my doing business.
Yes. True enough. But I think that cost should not be at the expense of the ultimate safety of the patient.
And I'm
So
still gonna push back and say I'm the ultimate.
it's always transferred back to somebody to pay for that ultimate level of care. It always will be. So it is I understand, and that is not something that we're just discussing today amongst ourselves.
Can I tell you real world
Okay.
what some of the issues are? So some of the malpractice insurers are refusing to insure the surgeon at the bedside as also the anesthesiologist. And so that eliminates the surgeon being a part of the anesthesia team when that happens. And so if you can't get malpractice coverage for being the anesthesiologist and the surgeon, then you can't do it at all. This model is trying to create a pathway where it can be done. Now, I'm like you, I'm trained in general surgery. I did not train in anesthesiology though. And so if a patient has malignant hyperthermia, I wouldn't know which medicines I'm supposed to push and treat the malignant hypothermia with. I would be in a pickle there. You know, when it comes to classifying ASA 1, 2, 3, or 4, I don't know the criteria for ASA 1, 2, 3, and 4. So all we're trying to do is bring a level of safety in with the anesthesiologist and then still let the surgeon who's at the bedside be the one who is immediately available for the care
Okay, so
of the
that,
patient.
thank you for that clarification, because the big caveat here that was not said before was that you can't get insurance to do it. So then now.
But some people
That-
can,
so-
some people can't. I mean,
So
so
then now that becomes an acceptable cost of doing business, because the return on investment of having insurance is much greater than the cost of paying for the consult of the anesthesia. That portion was left out before, so It
Not
does-
intentionally,
it does.
not
change
intentionally.
the tenor of it somewhat. However, it still does not take away the obstacles to doing business in this situation for a private practice physician.
if I may respond to that, I mean, our role here is to protect the patient. It's not to get into the economics of it. And really, the surgeon at the bedside shouldn't be responsible for the economics of it anyway. It should be the facility that bears that expense. Personally, and Kirk, you may know this better than I do. I don't know, but I would think that that's a billable participation that you, I mean, so.
Yes, there are different levels of, so there's direction and supervision. And if you parse those out, it comes down to a billing issue. Direction is the anesthesiologist is in the house and they can direct 4 non-physician anesthetists at a time. It used to be you could do an unlimited number. And that therefore you needed a lot less anesthesiologists. When they implemented the 4 at a time cases, rooms 8 through 12, you had to double the number of anesthesiologists produced. Certainly can't produce enough to have one, there is a need, and in my entire career, I've used APRNs to allow me to facilitate my expertise trickling down to as maximum number of patients in a safe way. So none of this has to do with who can do it the safest. It's obviously it's going on now with you being at the head of the bed, but I think it's, it's a matter of time before you are in that situation of malignant hyperthermia or something that you can't control. And those are the ones you don't forget. And so all the economics and all that are great, but you can't live some of those down. And we're just trying to be proactive and have
So
that availability kind of locked in.
to that end, then will there be any guidelines on the anesthesia consult part? Say, for instance, you're my consult, but you're also providing oversight for 3 or 4 anesthetists at the same time. I mean, will there be some safeguard that phone call can be taken during that time?
Yeah, and so again, like with our rules traditionally, like for everything we govern regarding licensees, we try not to get so specific that we end up pigeonholing the situation and making it more difficult for places to implement. I think that's very reasonable that if a remote anesthesiologist is available for consult, they can't be on the phone with 4 people at one time. So, but as it stands, there's no expectation that anyone be available. So that is a problem that will have to be sorted out and rectified by institutions in time. To have a pool of them available, where a rotating call system where can't get this one, you can get this one. And like I said, I think anesthesiologists understand the point I'm trying to make about prevention. They clearly know that your plan for that anesthetic is where the heart of the whole safety factor is. If you think about a plan deliberately and tailor it to that individual patient's health needs, and you have a plan for post anesthesia care, you limit, 99.9% of complications ahead of time. So, those considerations can go on not under the gun of time in the OR. Those are done pre-anesthetically. Like most surgery centers and hospitals have a pre-anesthesia evaluation clinic. And so if that anesthetic is expected to be general, that pre-anesthetic clinic that may be currently run by a CRNA needs to have an anesthesiologist for them to consult with. That kind of takes care of it. But all of these are considerations. I just don't know that delineating all of the expected possibilities is something that we could do. This is the baseline for that, but all those considerations are ones that will have to be had. So this is why we do this exercise, though. This is the first time we've presented anything like this. I don't know how long the previous rules were in place without a change. I mean, probably years. So this discussion is not pure fodder. We need to have it and decide what is the safest plan going forward. And so short of a governor opt-out, an anesthesiologist has been required to be a part of cases unless the supervising surgeon, as the physician of record, is willing to take on all that burden. And if you are, you can. Of course, if your malpractice insurer says not covering you, got to go somewhere else and do it where there's not that requirement. So it is where we are.
Any further discussion or debate?
Yeah, I mean, I think you've done a great job on this. I think we probably need to not necessarily vote on this, but at least maybe look at some modifications, some tweaks, because of, some nuances have come up,
That's
in
correct.
in discussion. And so I would maybe make a motion that we, the table, reassess, make some tweaks, modifications based on the comments. I think we're close. I think that's a great stat, but we're not in any imminent rush to.
Right, we are not.
Right. So that's the other good thing. And so we can sort of massage some of the,
Yeah. No, but that was my expectation, that we would not harden this today. Honestly, I would have been surprised if we did. I want this to be something that serves the purpose of protecting patients, protecting those who are trying to protect patients based on national standards and data that we have, period. So we need more time to do that, and I agree that we do based on some of the questions you brought up.
I would like to remind the board that even if you pass it today, it would still have to go out for public comment, and you would still have to take it up at another board meeting for final passage before it would go to the OLRC, which would include another public comment period.
Sure.
So even if you pass it today, there will be plenty of opportunities for modifications and changes to the rules, and that's part of the rule process. If you don't pass it today, then we don't start the process of going for public comment and making the modifications. I mean, we can make our own modifications, but we won't hear from the other stakeholders that may have ideas about how this should be done also.
Well, I'm sure folks in TV land will, we'll get some comments.
Oh, well, I mean, sure, we can take public comments on it. No matter what the board does today, it would just be a more formal process.
Sure.
If you go ahead and pass it today. And then, it moves things along in the process.
Yeah. So even though my expectations is that we might not push this forward, maybe that makes more sense to do so that we can get down to what's going to happen anyway, and that include all the other parties, and then we can still make the changes.
What was your question? I'm sorry, I didn't hear it.
Yes, I mean, basically, I'm saying, let's table it. Let's rethink some of the discussions and the points that have been brought forth. I'm sure folks who are watching will just probably say, hey, what about this situation, that situation? Y'all didn't think about that.
The process I'm trying to tell you about today, that just because the board passes it today, doesn't mean that has to be the final language.
No, I understand.
It can still be modified and changed. It starts the process of getting further comments and adapting the rules along with the comments.
I'd like to
Yes,
add
so
to
Rod,
that.
the TV land.
Yeah.
Folks.
Right.
We're going to hear from them. We want to.
Regardless, right?
So let's hear from them before we go make an arbitrary change and come back and then say, all right, now what do you think?
I got
it. That's all.
Okay.
Yeah.
I think we need the outside feedback.
Okay.
The best way to get the outside feedback is to pass it
Pass it.
today. That's
Right.
that's
and
my
then,
point.
And then it can be modified, right?
If I
Yeah.
could,
No.
if you do the first pass today, then you are required to accept public comments and you're required to consider them before you take it up again for a vote. Also, if at least 10 people or one state agency request a public proceeding, then we will have to have a hearing at which you can hear from all stakeholders. So if you, again, the public comment period, if you start that process, then you're required to consider all the submissions.
I got you. So to give you a double negative, to pass this or to not pass it would be to not move the process forward.
To rescind. your-
So I'll rescind and then I'll make a motion that this modification be accepted,
I say,
period, knowing the end result. And so my motion is to accept
Thank you.
I guess what we call it, the
Changes to the rule.
changes to the rule.
Okay, well, I'd like to thank Dr. Kinard for his report for the Rules and Regs Committee. Thank everybody for their discussion. I guess my
We need to
question
vote.
is, we're not prepared to make any modifications at this time. So we have a motion to approve the report from the Rules and Regs Committee, and is that a motion to accept these proposed rules?
That's correct.
Yes.
So do we have a second?
Yes, Dr.
yes, second.
Dr. Gersh, and all in favor of the motion, please say aye.
Aye.
Do we have any opposed? Say nay. Any abstentions?
Good job.
The motion passes. And thank
Lot of work.
thank the Rules and Regs Committee and everybody for your work on this. It seems like kind of a tough subject. It's 11:40. A lunch was supposed to be here at 11:30. Do we want to proceed with the next order of business, or do we want to break for lunch?
Gonna keep rolling.
Is there a possibility to finish the rest of the agenda, or is that too much to ask?
At this time, I think everybody wants to go ahead and move forward. I'd like to take a minute to recognize our court reporter, Anna Ruffin. thank you for being here. And Ms. Pam Ratliff, she's our Assistant AG and Hearing Officer. Thank you for being here. And the next order of business is an applicant licensure appeal by Dr. Eswara Kumar Mundra. Is that correct, Dr. Mundra? I'll recognize Mr. Barnes.
That is correct, Mr. President. Dr. Mundra is here represented by Mr. Doug Mercier, who the board is familiar with. Dr. Mundra appeared before the executive committee in July requesting a waiver of the ACGME training requirement, which he does not meet. His request for that waiver was denied by the executive committee. Dr. Mundra is here today to appeal that decision. I'm going to allow Dr. Mundra and his counsel, to carry this forward. But I would like to point out to the board that the new information of which I'm aware since that executive committee meeting is that Dr. Mundra has subsequently become licensed in 2 additional states. So that's the addition to the information that was presented to the executive committee in July. And if it's acceptable to you, I'll turn this over to Mr. Mercier and Dr. Mundra.
Yes, I'd like to take this opportunity to turn these proceedings over to our Assistant AG, Ms. Ratliff.
Yes, sir.
Good morning. Dr. Mundra, will you be speaking today and testifying?
Yes, ma'am. I'm sorry.
And this is an appeal of the EC's original denial.
Yes, ma'am, it is.
So the only new information is going to be the information regarding the 2 additional licenses.
Well, and any additional comments that they may offer
Okay.
live.
If we would, could we put Dr. Mundra under oath?
Besides, swear or affirm to tell the truth, the whole truth, and nothing but the truth. Thank you.
Is it your appeal? We'll let you go first.
Dr. Mundra. Good morning. As Mr. Barnes said, I'm Doug Mercier. I'm representing Dr. Mundra. The executive committee did have the benefit of the background information earlier. I don't know that all the other board members had that benefit. But what we're going to do, I'd like to just go through that with Dr. Mundra. The submission that was made for the May meeting, I think you have it before you, and Dr. Mundra has subsequently submitted a letter, I think has that same information. And as Mr. Barnes said, since that time, the status of Dr. Mundra has changed because he is now licensed in the states of Florida and Connecticut, which he was not licensed before. So I would like to ask Dr. Mundra to testify. Yeah. Dr. Mundra, would you state your full name for the record, please?
My last name is Mundra. First name is Eswara Kumar.
Dr. Mundra, you're here asking the board to grant you an unrestricted permanent Mississippi medical license as a waiver under the board's rules. What is your current licensure status?
At present, I am working at University of Mississippi Medical Center as an assistant professor and program director for the radiation oncology department. I am also a board certified radiation oncologist. I am in this radiation oncology department since 2015, and I am on limited medical institution license, ma'am.
Can the board hear him?
I can't hear.
Oh, okay.
Fix the mic.
Okay. Currently, I am working at the University of Mississippi Medical Center in a radiation oncology department as an assistant professor and a program director for the residency program. I am in this department since 2015 as a fellow, and then 2019, the department offered me a job as an instructor, And then 2021, they promoted me to as an associate program director for the radiation oncology. And then 2022, I became a board certified for radiation oncology. And at the time, they promoted me to assistant professor. And 2023, I am promoted to a program director. So I am in this residency program for almost 10 years. And I'm still maintaining my limited medical institution license. And I'm in a good standing certificate, and I don't have any medical malpractices. And I have almost like 18 journals on major articles as a co-author. And I also awarded twice as a best teacher. And I gave like grand rounds to the UMMC like 5 times so far.
Dr. Mundra, you stole about all of my questions here, just that one
Yeah,
recitation.
Yeah. So
let me just slow it down, just try to break it down a little bit so the board can digest this. Your current license is what?
Is a limited medical institution license.
Okay, and you've had that since what year?
Since 2015.
2015. That's the year that you went to UMC?
Yes, sir.
Okay. And when you went to UMC, that was for a fellowship?
Yes, sir. Yes. In 2015, I joined as a fellow in a radiation oncology department.
And how long did that fellowship last?
It was 4 years.
And then tell the board about the alternative path with the American Board of Radiology.
Okay. Before coming to the US, I am basically from India. So I trained in the radiation oncology in my home country, and I have a MD degree in radiation oncology. When I moved to the US, my first place is Mississippi. I joined here as a fellow. At the time, the American Board of Radiology has 2 options to get a board certification. One is the residency program. The other is alternative pathway. Alternative pathway is only the foreign graduates who have a MD degree for their home countries. But at the same time, the American Board of Radiology specifically mentioned that we should do this pathway in a radiation oncology department, which has a residency, which has ACGME accreditation. Because of that rule, only the American Board of Radiology allows us to do alternative pathway. So at the time, my department chairman wrote a letter to the American Board of Radiology with a sponsorship of 4 years of doing fellow with ACGM accreditation of radiation oncology residency. So that way I got that alternative pathway program. And then
let me interrupt you. So
Yeah.
the 4-year fellowship satisfied the criteria for the ABR.
Yes, sir, that's true, sir.
And you eventually became board certified with the ABR.
Yes, sir, that's
And what
true.
year was that?
In 2022.
Okay. And that's still
Yeah.
current.
Yes, sir. I'm still maintaining my certificate because during the time, because of the COVID, the exams are not conducted. So, I finally board certified in 2022.
Now, the reasons, let me back up. You made application to the board for this unrestricted permanent medical license, and you were turned down by the board, and then we went to the executive committee.
Yes, sir. That's
And the reasons that you were turned down, according to correspondence from Ms. Anna Boone, was that you didn't satisfy requirements of Part 2605, Chapter 1, Rule 1.1D, because you didn't provide proof of 1 year of ACGME approved postgraduate training in the United States or Canada, approved by the RCPSC or CCFP. And the second reason she stated was that you didn't satisfy the requirements of Rule 1.3B because you did not pass the US MLE within 7 years from June 22nd, 2015. Now, let's start with that. Why did you not tell the board, it's in the letter, but I'm not sure they've had time to read it. Tell the board, if you will, why you were unable to complete the passage of the US MLE within 7 years of June 22nd, 2015?
Because, at the time, during the COVID time, I lost my father and my grandfather. That impacted me, to recovery from that situation. And at the time, during the COVID time, also the exams were not conducted. So, that's the reasons, it took me to get from their loss, took me 2 years. So finally I cleared the step 3 exam in 2024.
So it's because it was during the COVID time and you lost both your father and your grandfather?
Yes, sir.
And currently, you are the program director for
Yes, sir.
what
For the radiation oncology residency.
at UMC?
Yes, sir.
Now let's look at your CV. You've provided that to the board. And I think you've gone through most everything, so we won't be redundant. Is there anything of particular note on your CV as far as your education or the articles that you would like to point out for the board or explain?
I think all of them are up to date. I don't have any additional things to add.
Now, also, among your submissions to the board, and I'd like to point it out, is the certificate from the American Board of Radiology dated effective May 18, 2022, for your board, for your certification by the ABR. The language there says that you has pursued an accepted course of graduate study and clinical work, and goes on to say, demonstrating to the satisfaction of the board qualification to practice. Has that ever been called into doubt by the ABR in any form or fashion?
No, sir.
Okay. Now, you also submitted a permit for use of ionizing radiation
Yes, sir.
from University of Mississippi Medical Center. I'll be honest with you, I'm not really sure the purpose of this. Can you explain what this is?
Because I'm a specialist in the radiosurgery treatment, so I do the treatment for the brain lesions. So for the brain lesions, we use the cobalt source that is like produce the gamma rays. And then for the radiation oncology patients, we use the photons for the treatments. So, and also for the gynecological cancers, for brachytherapy treatment, we use intracavitary. So in those cases, we use the iridium source. Like I'm authorized for all those procedures from the NRC committee here.
Is that a highly specialized field?
Yes, sir.
All right. And then the next thing that you submitted was the alternative pathway information. And I'd like to point out for the board, the next to the last page of that submission, it says about the ABR. It says, at the ABR, our mission is to certify that our diplomats demonstrate the requisite knowledge, skill, and understanding of their disciplines to the benefit of patients. Dr. Mundra comes to you today with this board certification, which the board says that he has a requisite knowledge, skill, and understanding. What he's seeking to do today is simply go from his limited license that he has at the practicing at UMC that the board has granted to allow him to have a full, unrestricted, permanent medical license. I don't think it's a question about his abilities. I don't think it's a question about his education or training. He has all of that and has had it for many years since he's been here. I've heard discussion about public safety, and that is what everything is about. I think sometimes we lose sight of public safety and we think preventing qualified doctors is adding to the public safety. Well, I submit to you that if you have a qualified doctor, that in all respects, preventing him from practicing or having full licensure, I guess I should say, could be a detriment to the public. There's really nothing other than, I guess I should say, the extraordinary circumstances of Dr. Mundra's past that brings him here today. Now, as Mr. Barnes pointed out, since the executive committee meeting, he now is licensed in Florida and Connecticut. So it really would be no different. You got two things to consider here. One is Dr. Mundra is here saying, okay, I'm appealing what I was here before in May for the executive committee, and that's asking you to waive the requirements and go ahead and grant me the permanent medical license under the, under the statutes and the regs. But he's also here as a physician who's now licensed in another state. So you have two sets of rules here. So I mean, this truly is an extraordinary circumstance. And Dr. Mundra is requesting that you consider those circumstances and grant him the permanent medical license, because this just doesn't occur very often, this set of circumstances. And now I think Dr. Mundra's willing to answer any of the questions from the board.
Does Paul want to ask questions first?
May I have one moment to confer with counsel? Sure.
I'd like to clarify for the board one thing. In the submission that was made May 7th, 2025, I referenced that the waiver rule was part 2601, but it's actually part 2605. I think Dr. Kinard had pointed that out during that executive committee meeting. And I talked to Mr. Barnes just now, and we agree that that rule 1.2 under 2605 is the waiver rule that would control that we're aware of. I'm not aware of any other waiver rule that would control the situation where you would go from a limited license to a permanent license under the circumstances that existed at the executive committee meeting. But now, since he's licensed in 2 states, there's a different set of rules that apply.
It's not my understanding that there are 2 sets of rules. It's my understanding that Rule 1.2 is the appropriate pathway. Having the licensure in the additional states is what makes Dr. Mundra eligible for consideration by the board for a waiver, which he was not at his previous appearance. Rule 1.2 says that to be eligible, you must be a graduate of an approved medical school, have a current unrestricted license in another state, and have at least 3 years of clinical experience. So now at that time of his original appearance, Dr. Mundra did not have an unrestricted license in another state. Now he does. And so my position will be that the board should consider those factors, the factors listed in Rule 1.2 in determining whether or not to grant Dr. Mundra the waiver he has requested.
Mr. Barnes is correct. I misspoke. I mischaracterized that. I apologize.
No further questions from you, Mr. Barnes?
No,
Okay.
based on that, I have no further questions.
Board members have any questions for the licensee?
Thank you, Dr. Mundra. I've got a question for the exact request. Is this a waiver for an unrestricted license? He's eligible for a waiver since he has an unrestricted license in another state. And Dr. Mundra he's working, at UMC. What is there a demonstrated need for an unrestricted license? I don't really understand the needs.
I'm not aware of a particular need, and that's not something that I think I would be aware of. Perhaps Dr. Mundra can answer that question.
I mean, like, for the people who are board certified, they need to have a unrestricted full license to practice.
to maintain board certification.
Yes, sir, that's true, sir.
Hey, real quick, Dr. Mundra, this is Dr. Roth down in Pascagoula. One
Yes.
quick question because I couldn't hear. So you completed radiation oncology training in your home country and then came back and did an additional 4 years of radiation oncology residency fellowship at UMMC. Is that correct?
That's true, sir.
Yeah, thank you very much. That's all I have.
And thank you, Dr. Roth. And one additional question is, so is he requesting a separate waiver for the exception to the time limit on the boards, on the passing the certification exams? Mr. Monsieur?
I think that is part of the waiver rule, if I'm not mistaken, because as I read it, the rule says, and I'd have to refer to it, I think it says notwithstanding the requirements of Rule 1.1, then it goes into the waiver. I may be mistaken, but I think that's the way it reads.
Rule 1.2. Rule 1.2 is the waiver. There's 3 criteria to be approved for a waiver. Be a graduate of an approved medical school, check. Have a current unrestricted license in another state, check. Have at least 3 years of clinical experience in the area of expertise, check. So that's the rules to be considered for a waiver. It's still up to the board whether to grant one or not, if those 3 criteria are met.
Is he requesting one waiver or 2?
One waiver will cover any deficiencies. I would say after those basic criteria are met, then the rule goes on to list multiple criteria for the board to consider. And I was going to cover those in just my closing statement.
Okay, thank you.
Any additional questions? There's no further questions.
Stay down.
Yes.
And now to answer your question, Dr. Lippincott, the rule says that, after those 3 basic criteria are met, and I am quoting, in determining whether to grant the waiver, factors to be considered by the board shall include, but not be limited to, the medical school from which the physician graduated and its reputation. B, postgraduate medical education training. C, appointment to a clinical academic position at a licensed medical school in the United States. D, publication in peer-reviewed clinical medical journals recognized by the board. E, the number of years in clinical practice. F, specialty, if the physician plans to practice in Mississippi. And G, other criteria demonstrating expertise such as awards or other recognition. The only thing I really feel like I need to add is that is not an exclusive list of factors, since the rule specifically says including but not limited to. But those are the specific criteria that the rule requires the board to consider in ruling on Dr. Mundra's request, and the board has the authority. It is still, though, it's within the board's discretion. It's not automatic just because Dr. Mundra meets those first 3 requirements. The board still has to decide in its discretion that those factors merit a waiver. And that's all I have, unless you have any questions.
Any questions for Mr. Barnes?
I'd like to make a motion to accept his application for waiver of the license.
I'll second it.
We have a motion and a second to approve the request for exception. All in favor, please say aye.
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 Any opposed, say nay. Any abstention? The motion to approve your request has passed, Dr. Mundra, and congratulations.
Thank you.
Can you hear me?
Thank you.
Thanks. So we have a few more items on the agenda. And if the board pleases, we can move ahead if y'all want to. Next item is approval of a consent order on Dr. John Keith McKelvey. Mr. Barnes?
Yes, sir, Ms. Hearing Officer. Is Dr. McKelvey online?
Can't hear you. Muted.
I believe you're muted, Dr. McKelvey. We still can't hear you, Dr. McKelvey. Could you hit your space bar? Oh. Hang on one second, Dr. McKelvey. We can see you, but we cannot hear you.
Unmute. Oh, is that work?
Yes, sir. Now we can hear you.
Okay, I'm sorry. It's the first time I've done this Zoom.
All right. And Dr. McKelvey, you and I have spoken on the phone, but this is the first time we've seen each other on video. And welcome to the board meeting. I just want to give the board a little bit of context and then ask that you be sworn because for a consent order to be approved by the board, anything that you say needs to be under oath. So I guess, Ms. Hearing Officer, should we go ahead and have Dr. McKelvey sworn?
Yes, let the court reporter swear him in.
Right, sir, can you raise your right hand? Do you solemnly swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
All right. And to the board for context, Dr. McKelvey is a physician who has been licensed in multiple states in the past. I believe his original state was Virginia. But I'm sure he will correct me if that's incorrect. He's also been licensed in 2 other states. He has applied to be licensed in the state of Mississippi. As you see in the consent order, in 2015, Dr. McKelvey had the unfortunate circumstance of, I believe, suffered from meningitis, and that condition left him with some level of physical impairment. In response to that, Dr. McKelvey entered into a consent order with the state of Virginia to limit his practice in certain ways. The other 2 states that Dr. McKelvey has been licensed in since that time, he has entered into similar consent orders. In considering his application, the board, acting through the executive director and the licensure division, requested that Dr. McKelvey agree to a similar consent order with this board. And Dr. McKelvey, did I state that correctly? Did I get any of the pertinent facts wrong?
Well, there are numerous details, but the total concept is correct. My illness was in 2011, and I was board certified in 4 states at that time practicing anesthesia. I'm board certified in pediatrics, and I worked at that point in time doing general anesthesia and had in the past worked at a Shriners Children's Hospital doing pediatric anesthesia in South Carolina. After my illness, I retook the written examination for American Board of Anesthesia certification and passed that with over 90% score. I took a course at Wake Forest for intraoperative emergency evaluation, passed that, and then took on a 6-month proctored working evaluation in Georgia, one of the states I was licensing in. My neurologist knew about it. All the medical boards knew about it. At the end of 6 months, the proctoring physician said, not quite there. So ethically, morally, I could not do anesthesia or pediatrics. And I've self-limited my practice to occupational medicine. And in specifics, I've worked for a company, the same company all these years, that we do mainly firefighter fitness for duty evaluations, hazmat, police departments. I currently have licensure in 6 states. The Virginia board was the first board to ask for the consent order. Subsequently, Kentucky and West Virginia were added to my practice, and they also the same consent order. All this time, I practiced without any difficulties at all.
Thank you. And Dr. McKelvey, since that time, practicing under these agreed self-limitations of your practice to occupational medicine, have you had any complaints about your practice of medicine?
I've had no complaints, either official or unofficial, none I'm aware of.
Okay, thank you. I have no further questions for Dr. McKelvey. I have no further questions. I'll have one final comment after, if the board has any questions for him.
Do any of the board members have any questions? No questions.
Well, then, thank you, Dr. McKelvey. I just wanted to make it clear that the reason why Dr. McKelvey is appearing before the entire board is this is a consent order, and therefore, it has to be considered and approved by the entire board. And so we agree with the terms of the consent order. Dr. McKelvey has shown his agreement with the terms of the consent order by signing it. The pages in the copy that were in my book were out of order, but the signature page is there bearing his signature. And so I would request that the board grant and the consent order.
I move that we grant the consent order for Dr. McKelvey.
Second.
All in favor?
Aye.
Aye. Any opposed? Any abstentions? The consent order stands approved.
Thank you, Dr. McKelvey.
Thank you all for your consideration. I appreciate it.
Okay. We have a few more items on our agenda, including an investigative subpoena. Do we want to break for lunch and do these after?
The subpoena is the only matter that would require the board to go into executive session. And I think after that, if you want to go, if you want to break for lunch afterwards, we can wrap this up very quickly after lunch if you want to go ahead and break.
So we want to do the investigative subpoena before lunch.
What's the litigation?
We
What's the
can, and
litigation?
you can go into executive session, stay right here, ask the other folks to leave. We could do the executive session right here, get the subpoena taken care of, and then move on to these continuances, which I do not believe will take long at all.
Okay. I can entertain a motion to close the meeting to move to executive session.
So moved.
Second.
To consider going into executive session.
Second.
All in favor?
Aye.
So the meeting is closed. Harry, Dr. Gibbons will, what am I doing? Oh. We'll ask you to report on the board's action, Dr. Gibbons.
I didn't write down the
2026-22.
2026-2. Okay, board met in executive session regarding issuance of a subpoena 2026-2. Board agreed that that subpoena should be issued. I'm sorry, 2 subpoenas, not 1. Thank you.
Thank you, Dr. Gibbons. Item 14 is a continuance in the case of Dr. Maxie Gordon.
Yes, Mr. President, Madam Hearing Officer, this is a first motion for continuance by Dr. Maxie Gordon. He informed us, or you see in the materials in your book, that he has retained new counsel and requested this first continuance to prepare for hearing, which will be in November. We agreed to this continuance that is appropriate and request that the board grant that motion.
Thank you. Any questions, discussion, or debate? Not, we can entertain a motion to approve the continuance.
I'll make that motion.
Second.
All in favor? Aye. Any opposed? The motion passes to approve the continuance. Thank you. Next item is a hearing in the case of Dr. Mary Jacobson. We have another motion for continuance.
Yes, sir. This is a second motion for continuance. This motion for continuance is in part due to the fact that I had a medical condition right around the end of August, early September, that prevented me from being able to prepare for a full evidentiary hearing. When the continuance was requested by Dr. Jacobson's counsel, after discussion with the executive director, we believe that was prudent and in everyone's best interest. And therefore, I request that the board grant this second motion for continuance for Dr. Jacobson.
Any discussion? If not, we can entertain a motion to approve this continuance.
I'll make that motion.
Second.
All in favor, say aye.
Aye.
The continuance is approved. Item 16 is hearing in the case of Dr. Joel Durinka, and we have a motion for a continuance.
Yes, sir. My name is Megan Geis, appearing as Deputy General Counsel for the board. This is a first motion for continuance by Dr. Joel Durinka. He has retained new counsel and will appear at the November meeting. So we ask that this motion for continuance be approved.
Okay. Do we have a motion to approve?
Motion approved.
A second?
Second.
All in favor? Aye. The motion carries. The continuance is approved. And item 17 is a motion for continuance in the case of Dr. Ardarian, Darice, Gilliam, Pierre.
And I would have certainly, I'll Ms. Geis continue, but this one requires a little bit of context, which she did not have. This is a second motion for continuance from Dr. Pierre, or perhaps a third. This continuance was necessitated because of the health of Dr. Pierre's counsel. He was undergoing a health condition that impaired his ability to practice and prepare for the hearing. We also had difficulty communicating with this attorney, who we deal with regularly. It was simply an unfortunate circumstance. It is now understanding. Dr. Pierre contacted us independently and stated that she had retained new counsel and asked for a continuance until the November hearing. We believe it is justified under the circumstances and request that the board grant that continuance.
Any questions or discussion? If not, we'll entertain a motion.
I'll make that motion.
Motion and second. All in favor of approving?
Aye.
Say aye.
Aye.
The motion carries. The continuance is approved. And item 18 is a litigation report.
That's correct. And this is an open, I'm not going to provide any confidential information, so we don't have to go into executive session. It is a matter of public record that there's a lawsuit that was brought by the American Association of Pro-Life Gynecologists and Obstetricians against this board and Dr. Cleveland in state court. The basis of that lawsuit is a state constitutional interpretation. We are being represented, the board and Dr. Cleveland being represented by the Mississippi Attorney General's office, specifically the Solicitor General's office. The Solicitor General successfully defended this board at the trial court, won at that level, and now the plaintiffs have appealed to the Mississippi Supreme Court. The Solicitor General will continue to defend us. I'm reviewing the draft brief that they have proposed filing for the board, and that will be filed next week. I just wanted to commend the Attorney General and Solicitor General's offices for the fine job they're doing and let you know that you're in good hands for the defense of this lawsuit. That's the end of the report. Unless you have any, I'll answer any questions.
Mr. Barnes, what was the preface of the lawsuit?
The premise of the lawsuit is that Mississippi has an abortion trigger law, which stated that if Roe v. Wade was ever overturned, then most abortions would be made illegal in the state of Mississippi. As we all know, Roe v. Wade was overturned in the Dobbs decision. The trigger law took effect, and indeed, most abortions in the state of Mississippi became illegal under that law. The plaintiffs in this case, it's unusual because the plaintiffs are not individuals against whom this law is being enforced. That's the typical pathway to a constitutional challenge, is that a government tries to enforce a law against that person, the defendant raises it and says this law is unconstitutional. Here, the pro-life gynecologists and obstetricians are individuals who support that law and are asking the court for a declaratory judgment that the law is constitutional. That's procedurally unusual and really inappropriate. And that's the basis on which the Solicitor General is defending the case. It's simply, you can't, it would be doubling down. And there's no need for that because there's no one against whom the law is being enforced. So therefore, it's simply procedurally inappropriate. These plaintiffs, in our opinion, and as the lower court, the Chancery Court found, do not have legal standing to bring this lawsuit. Did that answer your question?
Yes, sir. Thank you.
Yes, sir.
Thanks. Any more questions for Mr. Barnes? So thank you for your report. We don't need a motion, do we?
No action is necessary.
No action necessary. That was for information only, right? Okay. And the last item of business is meeting dates for our November meeting, and Dr. Cleveland had proposed a change to November 12th and 13th. It looks like
no, don't worry about that. I'm sorry.
Sorry.
That's just
it's
confusing.
It looks like shall we is it okay with everybody to meet next November 12th and 13th?
Yes.
Yes, for me.
Okay, but we will be meeting in November on the 12th and 13th.
Yes.
Do we have any objections to that?
See, that's a Mardi Gras. As you know.
You can't make it?
But I don't reject it. You've got a quorum.
Do we need to vote on that? We'll see. We usually do the EC on the Wednesday and we'll see.
Yeah, as things go, I mean, y'all saw we had a lot of continuances today, and I think everybody should mark their calendars for 2 days of hearings. So we would probably start, the current plan would be to start EC Wednesday morning, to be followed by a full board meeting the rest of the day Wednesday and all day Thursday.
Thank you. Thank you. Is there any other business to come before the board?
And just make sure Francis changes our schedule as soon as she can, so I can start filling the other times up.
I will make sure that happens.
Thank you.
Okay. Any other discussion or business? If not, the meeting is adjourned. There you go.